Professor Abdul Wahab. We'll discuss today ectopic pregnancy. Definition: an ectopic pregnancy is one which the fertilized ovum is implanted and develops outside the normal endometrial cavity. The sites are extrauterine and uterine, only 1.5%, and among the extrauterine cause, the most common one is the tube, that is the fallopian tube has got the majority, 97%, then 0.5% ovary, abdominal 1%, and in the tube ampulla most common, the anesthemus and infundibulum, very rare is interstitial, and in uterine cervical pregnancy, angular, cornual and cesarean. So this is what are the sites of implantation. Now coming to the tubal pregnancy, that is the most common, 97%. The frequency is increased, the incidence is increased. Why? Actual incidence is not increased, but early diagnosis because of the advent of ultrasound and also use of intrauterine devices. So the early diagnosis and treatment is a must, and that is the mainstay of the treatment. Coming to the etiology, salpingitis and pelvic inflammatory disease, and it may be iatrogenic because of the contraceptive issues like IUD use, intrauterine device use, sterilization operation, and use of progesterone only pill, and any tubal surgery. Any tubal surgery. So iatrogenic, contraceptive failure and tubal surgery, and intrapelvic adhesion because of any pelvic surgery, and assisted reproductive techniques use, overuse, and also it's common nowadays, and that is again predisposes to ectopic pregnancy. And other causes are previous ectopic pregnancy, prior induction of abortion, developmental defect on the uterus, and transperitoneal migration of the ovum to the contralateral. Presence of corpus luteum is also noted. So any factor which facilitating the nidation in the tube, that will predispose for the ectopic pregnancy. We'll go for the risk factors. We already discussed here. PID, you can see the PID here, and stiff tubal ligation, contraceptive failure, previous ectopic, other tubal reconstructive surgeries like tuboplasty, history of infertility, IUCD use, intrauterine contraceptive devices, previous induced abortion, and tubal endometriosis. These are all the commonest risk factors. And the rising incidence of ectopic pregnancies because of the more STDs, that means sexually transmitted infections are more, and ART pregnancy is more, and again the increased surgery, either sterilization or tuboplasty procedures, and detection rate is also raised because of the ultrasound, universal use of ultrasound in everywhere. And going to what are the changes happening in ectopic pregnancy. Well, the most important one is changes in the tube, what will happen in the tube, and changes in the uterus. So these are the two things, changes which happens because of an ectopic pregnancy inside the tube. Of course, in the tube, what will happen? As you know, there will be always the implantation occurs in more commonly intercolumnar fashion between the mucosal fold. The decidual changes will be there. Blastocyst will burrows and pseudocapsule forming, and blood vessels erode by the coronic villi, and there will be tube, and implantation site will be distended, and blood may be spilled from fimbria into the peritoneal cavity, cause hemoperitoneum, and stretching hemoperitoneum there, and trophoblast ectopic pregnancy do not usually grow, and it will, just like in normal pregnancy, as a result, production of HCG will be less. Okay, changes in the uterus, the decidua develops all characteristics except no, will be no chorionic villi, no chorionic villi, there will not be any villi. So decidia without villi is what we are seeing in the uterus. And nothing, if you not done anything, how will it will get terminated by itself, or what is the outcome if you are not doing anything? That is what is the mode of termination. If you are not doing anything, what will happen? So either it will go as a tubal mole, tubal abortion, tubal rupture. Depending upon the rupture of sites, there will be intraperitoneal and extraperitoneal, or it may go for a secondary abdominal pregnancy, and it may grow after this one. Just like the perforation of the tubal wall and amnion must be intact, and placental chorion should be escape, and herniation of the amniotic sac, and that will go, and placenta gets attached to somewhere, and that will goes to as a secondary abdominal pregnancy. These are all the mode of termination if you are not interfering. Okay, it's a beautiful pictorial. So you can see here with a beautiful picture, it shows the tubal mole, tubal abortion, tubal rupture, tubal perforation, and continuation of pregnancy. Okay, so what is secondary broad ligament pregnancy? Again, that is a rare one. Rarely the pregnancy may continue in the same process in the abdominal pregnancy between the two layers of peritoneum. Rare one. And for you, now the most important one is area-stellar reaction. What is it? It is characterized by the typical adenomatous changes of the endometrial glands, intraluminal budding together with typical cell changes. Okay, so that is not specific to ectopic pregnancy, but area-stellar reaction is an important change what happening in the uterus. Okay, and remember, there will be a vaginal bleeding. From where the vaginal bleeding comes? It is because the level of progesterone produced by corpus luteum will fall and HCG will be less, so that will cause what is called as withdrawal bleeding, and that is what is the cause of vaginal bleeding. Now coming to what is the clinical presentation or symptom of ectopic pregnancy. So for that, you first classify it into acute, unruptured, and chronic or subacute. Okay, the three type. And for acute, as the name denote, it is acute presentation or sudden presentation, and with the patient have got the history of missed period and pain abdomen, vaginal bleeding. So that is what is called as the classical triad. So patient will have pain, vaginal bleeding, missed period, history of missed period. Okay, so that is what is the classical history, and that is what is the triad. What is the triad? 100% cases you will get abdominal pain. Okay, 100% case you will get an abdominal pain. And 75% cases an history of amenorrhea, and lastly vaginal bleeding in 70% cases. Okay, that is what is the triad, the classical triad. Amenorrhea, abdominal pain, vaginal bleeding, with sometimes vomiting and fainting attack. That is because of the peritoneal irritation, vasovagal attack, or syncopal attack because of the collection of blood inside the peritoneal cavity. So these are all the signs. Now coming to the symptoms. Symptoms are the normally signs of shock, pallor, features of shock, abdominal examination will shows the tender, and pelvic examination sometimes extremely tender and it's difficult to perform, and you will get the signs of collection of blood inside the peritoneal cavity and pain. In pelvic examination you can see the pain during movement of the cervix, and no mass usually felt through the fornix, and the uterus may floats if in water, and caution the vaginal examination may sometimes precipitate the rupture due to manipulation. So cautious vaginal examination. So these are all the signs and symptoms of ectopic pregnancy. And this is all the acute presentation. And in some cases it will not rupture. This is only happen after rupture. If it is not ruptured, what are the presentation? What are the things? So if not ruptured, the ectopic pregnancy, if not ruptured, differential diagnosis should be in a sexually active woman, abdominal pain, this when the woman has got some risk factors. Okay. The signs, bimanual examination or a pulsatile small, well circumscribed tender mass may be felt through the fornix separated from the uterus in unruptured cases. And you always have a history of missed period, and TVS you will get the finding, positive finding, and in blood examination serum, beta Hg and laparoscopy will confirm your diagnosis. And in chronic ectopic pregnancy, the symptoms will be get mixed symptoms. Okay, you may not have a particular symptom or particular sign, but our classical triad will be there: history of amenorrhea, abdominal pain, and vaginal bleeding. And other symptoms, because of the chronic irritation, is a chronic presentation, chronic irritation of the bladder, dysuria, and chronic irritation of the rectum. So that's a rectal tenesmus and issue of bowel evocation, hematocele, all these issue, all these hematocele, chronic hematocele close the bowel and bladder symptoms. Okay. And other signs, patient look ill because of the peritonitis, pallor will be the feature of shock, temperature because of the infection is a chronic one. In abdominal examination we will get all the signs, and the Cullen sign is one sign which is there in any cases of intraperitoneal hemorrhage. It's not specific for ectopic pregnancy. And the bimanual examination, you will get an ill-defined boggy mass in the fornix or in pouch of Douglas. Rectal examination will give you the final. And examination under anesthesia or evaluation under anesthesia is an important way of getting the diagnosis clinically. And diagnosis of ectopic pregnancy nowadays very easy because of the advent of transvaginal ultrasound, laparoscopy, and beta Hg. Okay, so it's a classical history: missed period, abdominal pain, vaginal bleeding. Okay, in sexually active woman, whether married, unmarried, husband in Gulf or whatever. So you always keep in your mind ectopic pregnancy. But you have got the differential diagnosis. What is the differential diagnosis? An acute appendicitis, ruptured corpus luteal cyst, twisted ovarian tumor cyst, and rupture of chocolate cyst, perforated peptic ulcer. These are all the DDs of acute ectopic pregnancy or pregnancy acute presentation in ectopic pregnancy. In subacute cases or chronic cases, there will be absence of amenorrhea, absence of vaginal bleeding. Vaginal bleeding may be followed by pain, apparently normal vaginal condition, presence of bilateral mass, previous history of a tubectomy or PID infection. So investigations. Diagnosis investigation, Do blood examination for hemoglobin, ABO, blood grouping and CBC, and do a cultosynthesis. This is very commonly doing in the past, but after the laparoscopy and TVS, advent of laparoscopy and TVS is less commonly do. Estimation of serum beta Hcg, ultrasound, TVS, transvaginal, and combined ultrasound with beta Hcg, laparoscopy. The advantage is you can confirm the diagnosis and the same sitting you can offer the treatment also. Dilatation and curettage, you will get the chorionic villi, normal pregnancy, but here no chorionic villi inside the uterine cavity. So whatever you get the curette, you put in the saline, it will not float. That means there is no chorionic villi. So that is a confirmative sign or confirmative for the confirmation for there is no intrauterine pregnancy. It's an ectopic pregnancy. Serum progesterone and laparotomy at the last. In the past we use open and see if nothing is confirmatory. So you go and just open and see. But nowadays we do laparoscopy. That means you put the scope and see rather than open and see. Put the scope and see rather than open and see in the past. The differential diagnosis of subacute ectopic pregnancy are: number one, it is incomplete abortion. Number one is incomplete abortion. And number two is salpingitis. Number three is appendicitis. Number four is twisted ovarian tumor, ruptured chocolate cyst of ovary, and ruptured corpus luteal cyst. These are all the differential diagnosis of chronic or subacute ectopic pregnancy. And very rare tubal pregnancy is interstitial pregnancy, very dangerous. Here what will happen is it is associated with massive intraperitoneal hemorrhage due to combined vascularization by the uterine and ovarian arteries. Okay, because it is in the interstitial area, the vascularity from the uterine artery and as well as from the ovarian artery will be there. So it is a dangerous condition. Many times a torrential bleeding, massive hemoperitoneum shock, and sometime may ended up with hysterectomy.